Good evening, and thank you for inviting me for the CME on advances in management of diabetes. My talk is about management of hyperglycemia in hospital settings. This is an area that there is some controversy that I will try also to discuss, especially the controversies how much sweet is sweet when we treat diabetes. I am a consultant for ASI Corporation, and I hope not next year. Now, when we have acute illness, as you see here, we know there is increases in secretion of certain cytokines, stress hormones such as epinephrine, cortisol, and we also contribute to this therapy with our glucocorticoid therapy, parenteral nutrition, and patient has definitely decreased level of activity. That contribute and induce hyperglycemia, especially cortisol, especially TNF, tumor necrosis factor alpha, and or enteral nutrition or parenteral nutrition. Consequent to hyperglycemia, we know hyperglycemia affect secretion of oxygen bursts from monocyte, function of monocyte, affect wound healing, affect and increases oxidative stress, which consequent to that, we have endothelial dysfunction, which promote procoagulant state. Altogether, activating and deteriorating acute illness, which become a vicious cycle, which if not treated appropriately can end up with life of the patient. We know diabetes affects millions of people and thousands of hospitalized patients every year. In hospital, morbidity and mortality is markedly increased with poor glycemic control. There is abundance of papers, data, especially in late 80s and 90s, in every aspect of patient, whether it's MI, stroke, surgery, you name it, there is the role of poor glycemic control for aggravating morbidity and mortality of the patient. Now, hyperglycemia not only is associated with poor outcome, but is also a predictor of mortality. For example, post-operative glucose level are significant predictor of infection rates after cardiac surgery. In a study with diabetes and acute MI, elevated level of blood glucose at the time of admission predict in hospital and 1-year mortality. Similarly, in ICU, it has been reported that high blood sugar on admission is associated with increased mortality. In general, all as you see, post-surgical patient, acute cerebrovascular event, there is association between glycemia and the risk of death. And this increased risk is independent for severity of illness. So the question arose in 90s that this hyperglycemia is mediator of the poor outcome or a simple marker. It's just an innocent bystander as a marker. And that came and kind of shake the foundation of what DCCT, diabetes control study, that improvement of glycemic control has a better improved outcome of patients with diabetes, but in hospital mortality rates appear to be even higher for patients with newly diagnosed hyperglycemia. So this is the effect of stress that would affect the outcome of the patient, and including in between is the high blood sugar. So, or the question also whether, since we can decrease the blood sugar, so if this is a real modifiable mediator, that we should take care and improve the glycemic control and if that's the case, whether we should achieve a better outcome for the patient. So it seems it's something between these two. Hyperglycemia affect cytokine release and affect the severity of illness. Severity of illness by its own mediators, including endogenous cortisol, affect the glucose level, and these two acting against and putting forward the progression of the severity of illness. And we know taking care of glycemia in intensive care unit or any hospitalized patient has its own cost and time that needs to be spent. And studies came, which the landmark study that changed a lot, that was Vandenbergen study. Prior to this study, there was a study from a group that they were treating acute MI and use of insulin infusion the first 24 hours. They demonstrated insulin infusion improved the outcome. That was in 1997. The Vandenbergen study came in 2001. This is one center study and demonstrated that days after admission in the x-axis and days after admission up to 250 days, intensive insulin induced normalization of glucose is associated with better outcome in hospital survival and survival in intensive care unit. The blood sugar that they achieved, it was between 80 to 110. So it was very tight glycemic control with use of algorithm that was used at that time. So this study criticized and was a subject of intense challenge by other group that I briefly discuss in a few minutes. Vandenbergen, few months later, described the post-mortem of liver and muscle biopsy and looking at the glucose transporter 4 in two groups of those patients who did not survive. Immediately after their death, he took his biopsy needle and take liver and muscle biopsy with his group and demonstrated that good glycemic control in the black category is associated with higher expression of glucose transporter 4 and also hexokinase 2. Glucose transporter 4 is mediator of insulin for uptaking glucose into the muscle cells, and hexokinase is necessary for glucose oxidation in the early part of Embden-Meyerhof pathway. So it demonstrated that this is the basics of the effect of insulin, insulin-induced better outcome in those patients by improving their metabolism of glucose. So the question was how much sweet we should have blood sugar. In his study, especially I would highlight the effect of extensive and intensive insulin induced normalization of blood sugar on acute renal failure. Other conditions also demonstrated improvement in overall outcome in those category of patients in intensive care unit. So he concluded that not only mortality improves, the acute tuberous necrosis would be much less. Critical illness, polyneuropathy also decreases. Himself also demonstrated that most of this benefit we see is in surgical ICU. In his own paper, he mentioned very clearly that we didn't see this effect in medical patients. So what should be the target for blood glucose? So the sugar study, NICE sugar study in 2007 put a kind of shake all this Vandenbergen work and put the issue that if we do less intensive, we get better outcome, and the less intensive, that means having blood sugar around 140 to 180. By doing so, there was a lot of discussion. Finally, this paper came from Grisdale, and they did a real meta-analysis of 26 trials, looking at 13,500 more patients, including the 6,000 patients in nice sugar data, and demonstrated that the relative risk of death with intensive insulin therapy is equivalent to conventional therapy. And there was 6 times increase in rate of hypoglycemia with intensive management of glucose. But he also demonstrated by this meta-analysis that surgical patients would benefit from intensive glucose management. So the conclusion was, although there is a possible mortality benefit to patients admitted to the surgical ICU. So we keep this in mind in our management. So for a physician taking care of diabetic patients in the hospital, there are considerations that needs to be addressed from the very beginning. One, and the major one, would be severity of illness, use of glucocorticoid, and we know patient in hospital has unpredictable meal, there is tests to be done. So all these needs, and then there is all the time change to dosage. So communication of the physician is also extremely important. Also, knowing patient has diabetes or no would affect the outcome of the patient. And the recommendation actually of ADA is if there is a patient constantly elevated blood sugar more than 140, we have to do a hemoglobin A1C. And if it is above 7, we consider this patient as diabetes, and we should treat them with more stringency to treat their hyperglycemia. So management of diabetes start with pre-op period, and always there is need of consult for endocrinologist prior to any operation in hospital setting and in critical care unit. And traditionally there was a sliding scale which was commonly used to provide insulin in a graded fashion in response to establish hyperglycemia. So in a sliding scale, you treat the blood sugar of the patient, but you do not take care of the upcoming food that would increase the blood sugar, assuming that your sliding scale is perfect, that will correct your blood sugar. So sliding scale does not correct anticipated hyperglycemia after meals and causes substantial variability of blood glucose during hospitalization. Then insulin analogs came. We have at this time multiple insulin analog. This is insulin alpha chain, beta chain, sulfur bound between alpha and beta and between alpha itself. And then with modification of amino acid, we get different pharmacokinetics of the insulin. For example, in Lispro, we have exchange of lysine with proline reversed, so insulin, when injected subcutaneously, does not polymerize and rapidly absorb, so give us very rapid absorption. Or similarly, aspart insulin has the same effect in green, as you can see here. Addition of aspartate causes rapid insulin effect. Whereas addition of 2-arginine causes glargine, and this glargine is long-acting insulin that we use routinely in management of patients. Addition of free fatty acid with 5 amino acid into the beta chain give us detemir, and detemir bind to albumin in blood and causing slow release of the insulin. Now, when we look at pattern of insulin secretion in normal condition, like now we are eating, we have increase of insulin. So in patient with diabetes, we have two major components: basal insulin, which is insufficient, consequent to that, mirroring to elevated blood sugar. So this is one component due to glucose hepatic output. And the second component of diabetes is lack of insulin secretion after each eating. In normal person, we have a basal level of insulin with increase of insulin level rapidly to go back in 2 hours to the baseline, then after each meal, and then slowly in the evening time, we have few elevation of insulin when there is growth hormone, and at this time, some elevation around 2 o'clock in the midnight, growth hormone secretion, and cortisol secretion early in the morning. So when we eat, we have mirroring effect of glucose on insulin response. Now we have different insulin. I start with crystalline insulin or regular insulin, which is a kind of fast acting, but is not sufficiently fast and usually give us late the effect. So when we don't need the effect of regular insulin, we get the effect, and when we do not need its effect, we have it. So it's a little odd insulin response we receive and glucose response to this. And the reason is our blood sugar goes up 2 hours after eating maximum, whereas the regular insulin peak is about 4 to 6 hours. So it's a little late to give us a good response, especially in hospital setting. NPH has a peak, but is effective to manage blood sugar for 12 hours. So repeat 2 doses of NPH would give us better blood sugar control with low cost. This is NPH, or neutral protamine hagedorn, which described and done by Hagedorn in 1956, and we use this insulin with quite success. The next is those new insulin that are rapid acting, Lispro, Aspart, and Glulisine, which give us a peak starting very early at 1 to 2 hours. This is synthetic reversal of amino acid pairs and prevents formation of hexamer in solution. And monomer absorb rapidly, and consequently blood insulin level rapidly rise and bring down the blood sugar. In contrast, glargine, which is addition of 2 aspartic acid, arginine to the beta chain, give us a slow absorption. And this is because the company provide in the pH of 4, then get under the skin, reach the pH of 7, become crystallized, multimerized, and then very slowly releases to give us a basal insulin level which is constant and mimicking our insulin basal secretion. Similarly, detemir has this effect, but with a little peak, very similar to glargine. When we put all together, you can see you can achieve basal level with long-acting insulin, and with short-acting insulin like Lispro and Glulisine, we can have short-acting effect, the effect of the food that we have to bring it down to normal, while the long-acting insulin do its effect. If we don't want to use this long-acting, it seems use of NPH would be appropriate if we use twice a day, and then using those insulin, especially in hospital setting, the short-acting. So we have basal, the amount of insulin required to maintain normal fasting blood glucose, which we try to achieve with long-acting insulin. Bolus, the amount of insulin required to maintain normal postprandial blood glucose for any given meal. And correction, the amount of insulin required to return high blood sugar to normal. So if someone starts with blood sugar of 250, we give basal bolus, but you need to give extra insulin for correction. So this is now you see how using a sliding scale is a kind of knee-jerk reaction for the blood sugar without having any strategy to normalize the blood sugar. So as you see, we have use of regular insulin for a sliding scale in type 1 is completely wrong and then can cause ketogenesis and DKA in the hospital, and also is not sufficient to suppress hepatic glucose output due to the short nature of its action. And assuming someone has blood sugar of 256 and the 8 unit would correct that, what would happen if patient eats? So these two effects, lack of glucose production and not correction into that, make obsolete to use that. What we do in practice, and I do in practice, I use RABBIT-2 trial study that was published in 2007 in Diabetes Care, and is combination of glargine, long-acting insulin, and I don't use glulisine, I use lisproinsulin, again short-acting, and then we discontinue our oral anti-diabetic agent. We calculate the weight of the patient. Most of the time, the blood sugar is more than 200, so we use half a unit per kilogram at the starting dose. One half, say a person is 100 kilogram, we give 50 units. 50 units, we start half of that, 25 unit long acting, and we divide the rest, 8 units before each meal for the patient. And based to the response, we increase by 20% every day. This study also followed by another study showing improvement of outcome in those patients. This is what they published. This is the effect of a sliding scale. After 10 days, still blood sugar is the range of 180 to 240, whereas rapidly in 3 days, you can control your blood sugar, and actually by use of basal and bolus plus correction, you would strategically plan for better control during the admission of the patient, procedures that taken place. Say there is a patient with surgery that needs to be healed, you achieve in 3 days your goal of blood sugar, which, as I said, we try to be between 140 to 180 to be safe. And in those patients in the same study, when they did not respond to a sliding scale, they switched to basal and bolus, and in a matter of few days, they achieve what a sliding scale cannot do that. So the recommendation of ADA and ACE, American Association of Clinical Endocrinologists, is intravenous insulin infusion are recommended for critically ill patients who experience blood glucose level above 140 with a target of 140 to 180. We are not going to do any more 80 to 110. Lower blood glucose of 110 to 140 may be appropriate for patients following cardiac or vascular surgical procedures. In non-critically ill patients, the scheduled subcutaneous basal bolus insulin is the preferred therapy for achieving fasting and preprandial blood glucose below 140 and random blood glucose below 180. Consideration of more or less stringent target is based on patient clinical status. And definitely use of correctional insulin as monotherapy is advocated to not be used. Use of oral and injectable non-insulin glucose lowering agent have limited role. Oral agent like glimepiride and short-acting like nateglinide are effective sometimes, especially when patient is on glucocorticoid and is about to taper down. So we can use sometimes these two combinations, glimepiride as long-acting and nateglinide as short-acting. Both are cheap and we can discharge patients sometimes in that setting. This is my last slide and I'll be happy to answer any question if it's time. Thank you for attention.
What I will be actually discussing with you tonight is really the burden of diabetes care worldwide, effectively, and what we really need to do about it. Um, um, as you know, diabetes is usually two types. If you don't really mind, I'd like to stay here. Oh, he's recording. Ah, they do? Oh, dear. All right. Well, we'll deal with it. So diabetes is really two types, type 1 and type 2. As you know, that type 1 diabetes is about 10% of the diabetic population. Type 2 diabetes is the majority of the patients. About 90% of the patients with diabetes have type 2. And in general, diabetes type 2 is actually associated with lack of insulin responsiveness. There is some defects in insulin secretion, whereas in type 1 diabetes, it's really related to related. No, I actually speak over here. I have no problem. Okay. Right. I don't like technology. And type 1 is really an immune-mediated destruction of the insulin-producing cell in the pancreas that leads to development of type 1 diabetes. There are other intermediate, if you like, types of diabetes, like the genetic defect of the beta cell, such as the maturity onset diabetes, or what is now or has been known as MODY. The nomenclature is actually changing all the time. There are genetic defects in insulin action, and there are certainly drug or chemical-induced diabetes, and there is gestational diabetes and other forms of diabetes. So diabetes does not mean the same thing for every patient. It is different thing for different patients. However, the problem with diabetes, as I indicated, is actually a severe problem worldwide. And there is a significant increase predicted in the rates of diabetes worldwide. In 2013, the number of diabetics worldwide were about 400 million. They are expected to increase by 55% over the subsequent 20 years to about 600 million. That means that really currently there is one out of, there are 8% of the world population with diabetes, is really 1 out of every 12 people. And the sad thing is actually half of patients with diabetes are undiagnosed. They don't know that they have diabetes. And 1 out of every 2 people with diabetes, as I indicated, really they don't know the disease. The major increase in diabetes is really expected in the low-income parts of the world, in Africa, in the Middle East, and in Southeast Asia. There has been a significant increase in the rates of diabetes in the Western world over the last 30, 40 years, but the rest of the world is catching with this now. As you can see here, these are the number of diabetes in the different regions of the world, as well as the expected increase in rates of diabetes. And again, for example, in Africa, at the bottom over there, the rate of increase in diabetes over the next 20 years is over 100%. Whereas actually in the well-developed parts of the world, like Europe, is only 23% over the next 20 years. The issue is that in the less fortunate parts of the world, they don't have the money to afford the cost of care of diabetes. It also needs to be borne in mind that actually the incidence of diabetes is at its highest in the most productive years of one's life. Between years 40, if you like, and 70, is when you are mature and you are able to contribute to the society in a significant way, that's when you are hit with diabetes, whether you are a man or a woman. And it depends, whether in the earlier time or in the recent time, it is about the same. Sad thing is that people with diabetes die at twice the rate of the people without diabetes. And so the increase in incidence of diabetes is associated with increased mortality and morbidity, effectively. And again, depending whether earlier data or recent data, the trends are the same. Another way of looking at the cost of diabetes worldwide, there is one person dying of diabetes every 7 seconds around the clock. There is about 5 million people die from diabetes per year. And in fact, half of those die from diabetes are below age of 60. Showing really the significant influence of diabetes on the lifespan of individuals. As I indicated earlier, 77% of the people with diabetes currently live in the low or the middle income countries around the globe. 1 out of every $9, and in some places even more than that, of the world health expenditure is actually spent on diabetes. It is about 11% of the world healthcare expenditure in total. In some cases, it's 80% of that expenditure is really happening in the most richest countries of the world. For example, the United States by itself actually spends about 53% of the world expenditure in diabetes. And in some estimates, this is about $600 billion a year for diabetes, diabetes complications, and related problems. So it is a massive amount of cost. And if you actually, currently 1 out of every 3 American is pre-diabetic or diabetic. By year 2050, it is expected that 1 out of every 3 Americans will be diabetic. 70 million people in the United States by itself. Staggering, we cannot continue to afford that cost by any means possible. So the current way that we deliver the care for diabetic individuals is time-consuming. You have to come to the clinic several times. It's really a physician-focused. The physician is making the decisions for what you take as a treatment for diabetes, what medication, and effectively, largely a trial and error. The physician starts you on a medication, try you for a couple of months, you come back, you didn't respond, he add another medicine or increase the dose, you go again for a couple of months, you come back, and it is not very effective way of treating patients with diabetes. It is not necessarily a cost-effective way of treating diabetes because many new drugs coming on the market, much higher in cost than the older one, but are not necessarily better or more effective. However, when there is a new medication is out, everyone is trying to actually attempted to try that new medication with the hope that it may actually benefit them more. There are many algorithms that have been developed and recommended by the Diabetes Association, by the European group study for diabetes care, and others. But the implementation of these has become very difficult because actually there are many factors that are entered in these. And here is one of them. This is the most current one of 2014 from the American Diabetes Association. Nobody can follow it effectively. If you look at the other one that is actually recommended by the American Association for Clinical Endocrinologists, is even more confusing to me. And more so that some of the recent studies have suggested that actually if you attempt to control the blood glucose too aggressively in patients with comorbidities, you could increase mortality. So that you could not actually target, 6.5% of hemoglobin A1C in every individual with diabetes without really knowing whether that is going to increase the risk on these patients or not. For example, when they've tried to do that in a national study known as the Accord, they actually stopped the study because the intensive care arm was associated with higher mortality. So you have now to adjust the degree of intensity of the diabetes management based on the comorbidities that are associated with the manifestations of diabetes. Again, making the management of the individual much more complicated. In the 1990s, the NIH has funded actually a multi-center trial that was done at actually 17 or 18 centers in the nation, known as type 2 prevention trial, in which they actually tried diet and exercise in the high-risk patient for development of type 2 diabetes versus drugs. Originally, they tried insulin sensitizer, and when that killed some people, they actually switched to metformin. But what that study showed, that diet and exercise was able to reduce the development of diabetes in about 60% of those patients, whereas drugs were able only to reduce the incidence of diabetes or development of diabetes by between 28 to 31%, depending on which data you look at. Interestingly, actually, the older patients did actually much better. I believe that because they were more compliant with the treatment regimen that was given to them. So we actually, and the use of lifestyle modification, diet and exercise, is unanimously among all studies and all authorities, they agree on it's a class 1 recommendation and it's actually level A in terms of being uniformly effective in all of the studies that's been done. However, the implementation of this is very poor at best at the present time. I indicated to you before that we actually here in the United States are spending 52% of the world expenditure on diabetes. On drugs alone is about $10,000 or $13,000 a year, effectively in outpatient care of the diabetes individuals in the United States. Whereas in certain countries in Africa, the whole cost of diabetes care per year is no more than $7. Doesn't buy a box of strips effectively in the United States. However, with all of the expenditure that we do here in the United States, we are only able to achieve a hemoglobin A1C of less than 7% in about 50% of these patients. And in fact, if you look for the other comorbid conditions with diabetes, such as hypertension and hyperlipidemia, we are only able to achieve, with that tremendous amount of cost, the target goals for the treatment in about 18%. So with the expenditure of very large amount in the United States, still we are far from being able to reach the diabetes management goals. The other side of this is the fact that all drugs, you heard my dear colleague, Dr. Salehian, and talking about the various types of insulin and how to actually manage them, it's all medications are equally effective for the most part. All the diabetes medicine, for the most part, reduce hemoglobin A1C individually by about 1%, with the exception of acropose, perhaps, and the DPP for the inhibitors of such as Januvia. Those tend to be less effective than the rest of the medications in terms of reduction of hemoglobin A1C. So whether it's actually, yes, indeed, some patients require insulin, some patients require oral agents, but the magnitude of effectiveness is the same. And more so, even though that now we have, as Dr. Salehian have shared with us, almost 6 or 7 different formulations of insulin, you could control the patient to the same degree, regardless what insulin you use. It really depends on how you use it. And when you give the injections, short acting versus long acting. But whether you actually use NPH, which is very, very cheap compared to glargine insulin, such as the Lantus, which is probably 10 times more in cost, you can achieve the same control targets, regardless of the drug, if you use it correctly. Where that leads to us, it leads to us to actually the summary that the incidence and cost of diabetes continue to rise. Global disparity in diabetes healthcare expenditure, well, worldwide shortage of people who really can adequately manage diabetes. And current diabetes management is really tiered and physician-focused, trial and error, and insufficient patient support infrastructure for medical and behavioral therapies. We actually are not using diet and exercise to the fullness of its potential in managing patients with diabetes. So the bottom line that we really do need to think out of the box of how we manage a patient with diabetes to achieve the treatment goals. What else is new besides the new medications that we are bombarded with ads on the TV all the time with? Is actually there are a host of new technologies that are available to us. That if we can currently identify the diabetes earlier in the course of disease, we do need to reach maximum number of patients. We need to optimize the physician time and effort. We need to optimize drug recommendation by placing priorities on efficacy and cost versus availability. Is not just because it's available, I will use it. And we need to emphasize the lifestyle intervention and behavior modification. And we need, in doing that, take into account what is acceptable socially and what is acceptable for eating behavior, as well as, for example, if I come from Egypt originally, if you ask people to jog in Cairo streets, they will be run over by cars. And it's not in the culture for people to run around and exercise. The cities are not built to allow for that. So I think the whole thinking of our urban development, of our food packaging and development, of even agricultural development, it needs to be rethought in view of the burden of the disease and how we actually bring to bear everything together to make sure that we can make impact and actually continue to afford the cost of diabetes as we go forward. As I indicated a minute ago, that there is a lot of new technology available to us. Every single child around the globe has 2 iPhones in his pocket. We can reach people with these tools. We can actually have programs that actually developed on these, and we can actually monitor the patient's performance a day to a day through actually the use of this. There is also available to us, again, diabetes algorithm, but it needs to be done in a way that it can be managed. And we need, there are computer artificial intelligence, for example, that could be also brought to bear. And other electronic decision support systems that have been developed that actually can be brought to bear in the care of diabetes. So we decided here at City of Hope to actually do that, actually take all this information together and develop a way that actually electronically assess the patient metabolism and actually develop the patient specific treatment paradigm based on what goes into the patient metabolically. And we are doing this actually in collaboration with another group in Germany at Karlsburg in what used to be East Germany, where they have actually over the past 20 years developed a metabolic mathematical modeling programs for carbohydrate metabolism that could be brought to bear. We will be shortly launching a platform for management of diabetes. It's called ADAMS. It is an electronic decision support program to assist the healthcare providers in selecting optimal treatments for diabetes outpatient. The program invokes patient participation because you start with actually getting enough information from the patients to decipher this information and to decide on what needs to be done. The program electronically models in silico, software-wise, predicted glucose patterns and guides blood glucose optimization and drug therapy based on patient-own glucose monitoring data, current medications intake, food intake and preferences, and exercise level and cardiopulmonary fitness that exists in the patient at the time. In doing so, the program will generate metabolic fingerprints that can be visually interrogated in silico using real-time graphics that I will show you in a minute that enables the optimization of the care of those individuals. So what the program will do, it will start by actually selecting or taking information from the patients. This actually questionnaire that is answered by the patient provide the information. Part of it will be used for the mathematical modeling of the metabolism of the patient, and the others will go in registry. And as significant the diabetes is, we don't have registries. There is no diabetes registry in the US. It only exists in Sweden, actually, and Saudi Arabia. Then actually, based on the data that's provided from the patient, we can actually apply a NASA actually established program to calculate the cardiopulmonary fitness of that patient. That can determine for us the safe level of exercise that that patient can actually do. Patient will be presented with a menu of exercise that they can select what they can do based on their abilities within the boundaries that are allowed by the cardiopulmonary fitness level of the patients. And then actually the effect of this exercise will be tested again in silico before you can do that even before you see the patient. You can do the same with nutrition intake. You can get the records of the nutrition intake, you can analyze it, you can actually distribute the food intake of the patients using the ingredients of his own diet, because you cannot actually ask the patient to eat diet they cannot afford. So you need to look at the diet elements that the patient is taking, what is good, what is bad, and you distribute this to reduce the bad and to augment the utility of the good. You tested that also into the system to see how much optimization you achieved with the diet management of that patient. And then you apply algorithms for drug therapy, starting with the cheapest, most effective drugs, and you build, and again, taking into account patient own preferences. Patient who wanted only use an oral agent, you should not be giving him insulin unless the insulin becomes a necessity. And again, you can take the patient weight into account in deciding medications. All of this can result at the end in actually a treatment paradigm that actually optimized and that can be given to the patients and the treating physician to implement. This data can go into the registry so that we can have a follow-up to know what we are doing in the care of those patients and whether we are influencing their outcome or not. Here is how this mathematical modeling is done. Once you actually get the data from the patient, regardless whether you get it a paper or you get it on a tablet, you get it on a computer, they do it from their home, it can go into the registry, and part of it is used to generate This is what the one in dots here is the patient's own measurement of blood glucose. The continuous line is the mathematical modeling. And you can actually drive that to all the constituents that went into it, where the diurnal variation in insulin sensitivity, the drug intake, the food intake, the physical activity, the oral agents. And by modifying these in silico, you can optimize the blood glucose of the patient and bring the patients within the target range, which is the green area in here. Here is all red, here is mostly green. And again, this is also shown clearly in here. This is before the optimization of that patient, and you can see that all of the values of the blood glucose are above the desired range, and here after that patient has been optimized using this in silico models, which can be done electronically. You don't even need a physician to do it. So with this, we could streamline the management of diabetes on a global scale. We can make this available to everyone around the world. We estimated that in the United States, if we actually save 10% of the cost of diabetes care, that would save the healthcare system in the US $36 billion a year. This has to be developed on a culturally relevant nutritional and behavior modification, as I indicated to you, and is actually would allow us to start developing worldwide diabetes registry if we are able to disseminate that worldwide and actually analyze, store and analyze the data that we generate from patients globally. I believe this is the last of my slides. Thank you.
Most of my talk is artificial pancreas. And as you know, this is a closed loop. The insulin secretion, the food, glucose goes up, pancreas, beta cells, alpha cells respond, and we get a loop. Now, with using artificial pancreas, we are going to close the loop. This is my talk today. So with this introduction, we know from DCCT, Diabetes Control and Complication Trial, that lowering hemoglobin A1C level to 7% with intensive treatment versus 9% with conventional treatment, that decrease the risk of development and progression of early retinopathy by 50 to 75%, nephropathy by 35 to 55%, and specifically neuropathy by 60%. So it was recommended by DCCT trial that most children and adults with type 1 diabetes should be treated with intensive therapy to prevent or markedly delay the development of diabetic complication. So why do we need an artificial pancreas? Too many type 1 patients fail to achieve target hemoglobin A1C. And as you see on my previous slide and Dr. Kandil's, only 20% can achieve in children. And also rate of severe hypoglycemia and very sad event we call death in bed in type 1 diabetes still remain a significant problem while we are treating type 1 diabetes with intensive glycemic control. And if we don't, then we have to deal with DKA on and off. You go to Harvard UCLA, is in diabetes clinic is maybe the saddest clinic you can go, is compared to cancer patient, I would say is much sad to see young people blind, lost their limb in the diabetes clinic in the county hospital. And too few pediatric patients take full advantage of advances in diabetes technology. Dr. Kandil is one of the leaders of islet transplantation, and islet transplantation include pancreas of a donor to be removed from his body, beta cells in his lab separated from these tissues in separate islets, prepared and inject to the portal vein of the recipient to go to the liver and then induced treatment of diabetes type 1. This is in competition with artificial pancreas. They are competing against each other, and actually Dr. Kandil competed with himself too to develop artificial pancreas. And what is an artificial pancreas? Is an insulin infusion pump, continuous glucose monitor to constantly every minute, at least 20 times every 5 seconds, sending signal for the level of blood sugar based on hydrogen ions that coming from a glucose oxidase that is underneath of the skin. So this enzymatic pathway releases protons. Proton activate the sensor based on the amount of separation of protons give you the number of blood sugar. So protons level or hydrogen ion give you the level of the blood sugar, what we call continuous glucose monitor, 20 times per minute. A control algorithm that I briefly discussed, a use of rapid acting insulin, whether Lispro or Aspart, and then whether we can use also glucagon as dual hormone. This system is an evolving process. This is a system, and we call AP is a system that is evolving. And the system is set to reduce or stop insulin delivery to prevent hypoglycemia or impending hypoglycemia as a hypoglycemia minimized system. So as I discussed, you have the insulin pump, you have the sensor, glucose monitor, which is this attached underneath of the skin, responding to there is glucose oxidase underneath of this needle. When blood sugar pass through, glucose oxidase separate the glucose and hydrogen ion separate proton. This is a kind of pH meter actually. And then this transmit this glucose sensor by knowing how much is the glucose, send signal to the insulin pump, and insulin pump change the level of the insulin delivery per minute or per hour. So this is an integrated system, and this is the world's first integrated system of insulin pump system with real-time continuous glucose information. You have the real transmitter, real-time trend graph, real-time alarm, trend arrows that the blood sugar is going upward or doing downward, and real-time reading 4.6 millimole per liter, or say about 85, something like this. So all this costly, $55 for 10 days, so $150 a month. The insulin pump, about $12,000. The setting, connections, all is very costly. So this is what Dr. Kandil's study showing the concept of glucose sensing and amount of real blood sugar at every single point with meals, and the insulin that is necessary to bring down the blood sugar. So insulin starts to go higher to bring down later the blood sugar. So there is rapid increase of blood sugar, rapid decline. You see the decline is when the blood sugar is rising. So is a little delay between these two that this algorithm developed based on this modeling, mathematical modeling of this system. So do we need artificial pancreas system? We know that this management of type 1 diabetes, patient needs to 6, 7, 10, 15 times checking the blood sugar, and the need for care is humongous. the patient should take care of himself so much. Despite all we know from DCCT, glycemic control is very suboptimal if it is not disastrous. And there is a large opportunity for significant improvement in type 1 diabetes and for sure for type 2 diabetes. As we mentioned, 20% of children have a target blood sugar and 40% of adult. Frequent hypoglycemia and ketoacidosis. And why is diabetes control is not achieved in majority of patients with diabetes? Tools available today do not easily allow us for normalization of glycemia for patients lacking beta cell. Self-monitoring, continuous glucose infusion of insulin via pump, and boluses to be given an insulin to correct hyperglycemia all needs the knowledge of how much carbohydrate to take for each amount of carbohydrate per gram, how much insulin you need to take, and this needs to be automated or automatized. Low glucose suspend might partially improve, but is far from a final solution. And we know continuous glucose monitoring trial failed to demonstrate that applying this system would improve more the glycemic control of the patient with type 1. It is highly unlikely that at this level of our activity we will be able to normalize glucose through subcutaneous insulin infusion and replacement of insulin even with combined glucagon. But we will be able to decrease glucose excursion, decrease episode of hypoglycemia, and we should compare normal physiology with pathology and improve the pathology to near normal physiology. So we are far from physiology, but we can get close to near physiology. And the roadmap is going to be the next 6 slide that is in process at this time. So step 1, low glucose suspend. This is available and this is threshold suspend. What it does, insulin shut off on the pump. When we set a preset threshold for blood sugar, so patient is in bed, sleeping, blood sugar dropped to 450, 52, patient pump stops. This is now commercialized globally, and there is supporting data demonstrating reduction in severe hyperglycemia and maintenance of hemoglobin A1C. Its cost is still an issue. Number 2, the second system. This is not when the blood sugar goes down to stop, but that predict low level of glucose to suspend. So PLGS, predictive low glucose management system. Insulin shut off when this system sees there is impending hypoglycemia, that will stop, decrease the rate, and let blood sugar back up, and then continue on the same. This is in the process of approval by the Australian government and actually commercialized in Australia. Data supporting that, showing the reduction in hemoglobin A1C and decrease or reduction in moderate hypoglycemia. This is interesting hypoglycemia, hyperglycemia minimizer. So this is to treat to range system or TTR, automatic insulin dosing when blood glucose increases. So it does not target euglycemia, just decreasing the time that patient has hyperglycemia. And the set is for 180. So it's not looking for hypoglycemia, it's to keep to range in certain level at all the time, avoiding postprandial most of the time hyperglycemia. The next is hybrid closed loop or target to treat system. The algorithm written to aim at euglycemia target relies on mealtime insulin bolus. So not just avoiding outside range value as opposed to previous form. This is to keep it within normal range. And supporting data showed reduction in time spent hyperglycemia and hypoglycemia, and increased time being in the target range in outpatient setting. This is one of the very first one that is studied. And then fully automated insulin delivery, which is fully closed loop, automated insulin delivery system with minimal human interaction. There is this proof of concept study and is in the process. And recently, there is data published in New England Journal of Medicine. There is significant reduction in hyperglycemia and almost zero reduction, 0% of severe hypoglycemia in that system. In that system, they described, I didn't, for shortage of time, didn't put this data, but it's interesting that compared to conventional insulin infusion, we really decrease the severe hypoglycemic event. Then we have multi-hormone or insulin glucagon system or bionic pancreas. This is going to be commercialized very soon. The data presented recently, again, very recently, in New England Journal of Medicine. This is reduction in hyperglycemia and hypoglycemia. This is study done in 3 separate days in 3 categories of patients. They are crossovering from each other, and this is increasing time in euglycemic condition in outpatient setting. So we know there is competing progress in cure of type 1 diabetes, islet transplantation with use of anti-thymocyte globulin started at City of Hope. We have bionic pancreas. We have mesenchymal stem cell diversion to islet formation, again in progress under leadership of Dr. Kandil. And at the end will be the patient choice, and in my view, the market, the demand. Which one promotes the best and challenge others as be the best product that patient can use. And as we know, the market promotes the discoveries and challenges of new products will ultimately decide the fate of each discovery. So my concluding notes in this progressing technology is the burden of management of diabetes led to development of different approaches for glycemic control in type 1 patient. Among the 3 competing solutions for improving the life of patients with type 1 diabetes, the artificial pancreas or bionic pancreas has been the most promising. And the new technology for the bionic pancreas would be adapted by patient and physician only if we can decrease the burden of diabetes and the cost of management while achieving an excellent glycemic control. Thank you for your attention.